Welcome to episode 96 of the ASC Podcast with John Goehle for March 20th, 2020. We're recording live from our studio in Spencerport, New York. We would like to thank our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, and Encompass Healthcare Data Solutions.
And we do have one more new sponsor. It's not in the script. It's BHG Funding joined us yesterday.
Okay, and BHG Funding. For more information about our sponsors, please visit our website. This is Sue Cronkite, Chief Researcher for ASC Podcast and Senior Nurse Consultant for Ambulatory Healthcare Strategies, and I'm with John Goehle, who's recognized as one of the nation's leading experts in the ambulatory surgery industry. And joining us remotely from Rochester, New York, Jenna Alvarez, Senior Nurse Consultant with AHS, Alex Borneman, Director of Operations with AHS, and Judy D'Ambrosio, Director of Educational Services with AHS. From Cape Cod, Massachusetts, Lori Rodricks, Director of Clinical Services for AHS, and from Atlanta, Georgia, Zach Kalaridis, Financial Consultant with AHS.
And Ann Geyer is also available online, so she's standing by in case we have some questions for her. This is we're just kind of going off the cuff right now. So the reason we're live, even though we had hoped not to go live today, is because the governor went on at 11 o'clock today and issued an executive order. Basically, the order indicated that that 100% of the businesses in the state of New York are to shut down, with some exceptions. At this point, those exceptions are being defined, but healthcare is one of those exceptions. The issue is going to be that at the same time that he issued this order, he indicated that all non-elective surgery should be stopped. We have asked for more specific guidance, and it will be forthcoming again, our governmental consultants, the New York State Association, all have been asking for guidance on this. So I'll give you some of my feelings in a bit. The biggest issue that the Department of Health is working through right now is trying to find ways to expand surge capacity. In other words, trying to convince, and what we're trying to do is we're trying to convince the healthcare industry that ASCs are here to take what the hospitals need to stop doing. So as we go into this shutdown, or as we start trying to figure out ways to increase the capacity of the hospitals to do those things that are directly related to taking care of patients that have that have been affected by COVID-19, we hope to that we'll be able to take off all of those responsibilities that the hospital has for doing cases that could be done in a surgery center. So I want to emphasize here. So a big question was asked to me minutes after that conference call, or I'm sorry, after that the governor's announcement is, should I shut down? And in talking to a number of our clients, including some of our orthopedic centers, the doctors pointed out how they might sound like they're elective procedures, but there are some ramifications for, not shutting down those types of cases. So here's our best advice right now, is that we as physicians should be the ones that are making decisions about what cases are elective versus non-elective. But we need to make sure that we're not pushing the limits on that. So, I mean, if like plastic surgery, let's face it, most of the plastic surgery, breast augmentations, for example, at this point, I think we can all agree, perhaps, maybe not, but perhaps that's an elective procedure. And I want you to, I do have somebody calling in. Hang on one second. And I think we have to be very careful that we don't overstep our.
You want to be sure that we come off as authorities to make that decision, whereas if you're not making good decisions, somebody else may take over that.
That's right. That's exactly right. We have spent a lot of time providing information for you as to how to document any decision you make. It is extremely important that you document in board meetings what the decision-making process was. And again, on our website, we have forms that can help you do that. So you need to hold an emergency board meeting. We've done for today alone, document those meeting the decisions that were made in that meeting. And Lisa's online. Hang on one second, Lisa. I'm going to let you in. Hi, Lisa. Thanks for joining us.
Hi, John.
So we were just talking about some of those decision-making processes that we need to go through. So documentation of your decision, Can you handle some of those? Documenting some of those, documenting those decisions in your governing body minutes, using one of the forms that we've put on the website to document every single decision that every case that you decide to do and if decided is not elective is absolutely critical at this point. The governor has indicated that there are going to be civil penalties and perhaps even shutdown orders by the state if they feel that you have not made the right decision. Now, we do feel like healthcare is one of those areas that's exempt, but again, it's not a blanket exemption because they have also at the same time said that that you should not be doing elective procedures. I have a whole bunch of questions. Mm-hmm. Let's try to take some of them one at a time. Go, Sue.
Okay. So Christina wanted to know what is elective versus emergent.
And again, those decisions are at this point being made by the physician. Let the physician determine what he determines is what he feels is elective versus emergent.
And having a lot to do with how serious would be a postponement, how they will, how
what the long-term effect
prognosis
would be.
And that
Correct.
Kind of thing. She's also wondering about urology procedures, which is probably the same type of thing.
I would say the same answer, and I think that it probably was urology more so than that particular center also does eye cases. Urology more so than probably eyes, unless you're talking about retina procedures, are probably more likely to be not elective.
I have just a piece of that, John. If I
sure, go, please.
So when we just finished a conference call with the Ambulatory Surgery Centers for New York State, we said, can you not do a procedure? What does it mean if you don't do this procedure, there could be harm? And I think if you really dive down into the weeds with that question, I think then you'd be following the intent of the governor.
Right. Well said.
And another question, which following up on that is Stephanie wanted to know, what about GI? And I guess it's the same kind of thing. There may be some screenings that can be put off, but if somebody's having heavy bleeding or suspicion of a very serious disease, then you would probably be able to do it. So it's going to be just procedure by procedure based on the patient and.
That's right. And I think when it comes to GI now, I heard Annie, and Annie, if you're on also, it might be interesting for you to call in too. Annie is with Physicians Endoscopy, and I understand that Physicians Endoscopy is pretty much closing down many, if not all, of their sessions. We are getting tons of questions here.
They want to know, do we need to restrict to urgent only by Sunday? And I believe that is what he's saying.
Yes,
and I think that the term urgent hasn't been defined. So, and none of this has been defined. Again, repeating what I've said before, it's the decision at this time is still in the hands of the physician as to determine what is an elective versus a non-elective. Those are the terms that we're using right now, as elective versus non-elective or essential versus non-essential. So try to use those terms when you're making this. I don't think we have a problem with you defining things, as broadly as you might want. Just kind of use common sense.
Sunday would be the effective date, correct?
That is correct, right, Lisa?
Yes, Sunday.
Now, I do want to mention another thing is that I think what we're heading for right now is an acknowledgement that we're probably going to be slowing down our procedures or terminating our procedures, but as Lisa talked about before during her session, and which I believe has been the case all along, is that at some point we're going to need to be part of the solution here, as hospitals are focusing purely on taking care of those patients that have those patients directly related that have problems directly related to COVID-19. They're not going to have time. They're not going to have the staff. They're not going to have the resources to be able to do surgery. Because there are going to be surgical cases that have to be done that are urgent. We might not be the ones that are doing them right now. They might normally be done in the hospital. And I think we're going to have the hospital start calling upon us. And Lisa mentioned, and I agree, that we want to start to be proactive with the hospital and with your local emergency services and saying, hey, listen, don't forget we're here and we're willing to take things on. Now, part of that could very well be that, oh my goodness, I'm sorry, I blocked it. That could very well be that your nursing staff, the hospital's going to say, listen, I need your nursing staff over here. So keep in mind that be careful about what you ask for when you when you contact the hospital. Go ahead.
And Jackie wanted to know if this includes ASCs in New York City as well, and I believe it is.
It's the entire state.
Yes.
Yeah, there's a New York City versus upstate
and
issue
it sounded
anymore.
like they were even going to be, they're drawing in the neighboring states, so I think this is going to be pretty broad.
One point, John, in regards to the in the evaluation and reaching out, one of the things that's really critical in the emergency preparedness field and your pandemic flu planning is really looking at a regional approach. And so some of the New York State groups, the ambulatory surgery centers, have been great, where they're saying, hey, you're down the street from me, you're a sister facility, I'm going to shut down to a skeleton crew. They're going to close and we're going to work together.
Right.
The same thing's going to go for what are you hearing from your local health department or your Office of Emergency Management? If you haven't heard from them and you haven't heard from the hospital, it's also really important. You are probably part of their surge capacity to also just send an email or call into them. You may not hear from them right away, but as they start to roll and peel the onion on this, you may be getting involved. So I think look to your regional as well as just the state for capacity.
And we've put a letter or a recommended letter up on our website, ascpodcast.com, that you can send by email or by carrier pigeon, whatever, to your hospital and to your regional office, just to remind them. It's important not only that you contact them, and if you can't get a hold of them in person, to tell them not only that you're there, but also what capabilities you have, so that they know they can start thinking about that.
Okay. And Alex, did you have a comment about New York City?
Yeah. So for New York City, we can't forget that the executive order from Mayor de Blasio is still in place.
That's correct.
So that would be effective on Friday. So you have an earlier date in New York.
Okay.
Good point. Thank you.
Yes, definitely.
I feel weird, Lisa, kind of reiterating some of the comments you made, but at least now you're here to alliterate, to add additional color to it if I don't say it correctly. So as Lisa said, be very careful about pushing the limits on defining the cases that you're doing. Jeffrey called in and said he and I think it's a great idea. It's a great idea to create a log of all of the patients that you have decided not to do, so that you can document that you're going both ways here. And of course, if you have a log that has nothing on it, then you're going to have a hard time justifying your decision-making process. So definitely create a log. Judy, when you have a chance, can you create a new log for that? And we'll post it up on the website to give people an example.
And another question. And thanks everybody for all these questions. It's great. So Fergie wanted to know regarding equipment and supply. She's basically asking, I'll just read it. I'd assume every unit would be stocked with what it needs, but are they at the stage yet where you may be told, okay, this place is getting overwhelmed, we need to take your equipment away and put it where it's needed more? Or is it a case of what you have stays with you unless you offer it up, as long as...
Great question. So one thing that we did get from the governor's conference this morning was he indicated that if you have ventilator units, please call them. They gave an 800 number. I did post that 800 number on the morning update. And please call them and offer it up. I think they did say that there'll be reimbursement for it, either sell it to them or rent it to them, but they need it desperately. And of course, we have to be careful because most of us don't really have the ventilator type units that they're looking for there. We have units that, would last for only a short period of time. I mean, using a ventilator on an anesthesia machine, for long-term care of a patient is really not the ideal situation. So I'm not sure how much that really affects us. Any observations from my staff about that? Or any additional comment, Lisa?
No, I think you're correct.
But to your point, anything goes here. Under 1135, the government can step in and say all kinds of things. Good news under 1135, it has to be in writing, it has to be very specific. Mm-hmm. Lisa has said that she's in constant contact with the department and to make sure, and thank you, Lisa, you've done a great job in making sure that they know we're here and that we're ready to help out. And Lisa also mentioned that the regional office is the front lines of this, so it's important that you contact your regional office. Lisa, the New York State Association, and all of us are kind of doing things at the state level, but your local office is ultimately the one that's going to be making a lot of these decisions. So I guess one big comment I want to make is that in a short term right now, I think we are looking at either the possibility of shutting down or limiting our services. But in the long term, we're going to be called upon to come back online for whatever. And it could be because the hospital is asking us to take on cases. Maybe they're coming to us and asking us to be a collection point. We have to be ready for any type of a situation. And one comment that was made, or one thing that I need to point out, is that be very careful with how if you are going to shut down, if you are going to limit, if you're going to let employees go during this time frame, be very careful about the terminology that you use. Work with your lawyer, work with your benefits company, because the proper terminology is probably a furlough as opposed to a layoff. A furlough is a temporary stoppage of an employment, basically where you're acknowledging that person is going to come back at some time in the future. And the reason for that is, from a regulatory standpoint, if you lay somebody off and then bring them back on board, technically you need to go through that whole onboarding process again. You have to fill out all that paperwork. You're going to have to get all the payroll information redone. You're probably going to have to do new orientation, et cetera. So if you intend to bring those people back at some point, furloughing is the proper terminology. The other thing with furloughing, as I understand from my legal people, is that you're generally, first of all, you are able or eligible to take unemployment insurance, and your healthcare benefits continue at least during that time frame of the furlough. I'm not sure how long that goes, but that would, and I think most of us are hoping. I hope most of our employees are hoping that they can, that they want to maintain that coverage for their employees during this difficult time, so that it's very quick to be able to bring them back on board. Should we have a review process on all cases by an MD specializing in that area? I think the question there is leading down to how are you going to? I'll state that I think what it comes down to is, I don't know that you have to have multiple doctors making a determination as to whether it is elective or non-elective at this point, based upon the most current information I have. So let's not overburden our process here. Let's recognize that doctors certainly should have the ability to make a determination on their own without having to consult other individuals. Other questions anywhere?
Nope. Any
other comments at this point? As I check on my my notes, we have a huge audience here. Thank you. So if we have questions, and you've been sending them in, if somebody wants to call in and ask a question, feel free to do that.
If you do call, sometimes if you text first, or if we don't have your name and we don't recognize your name, because last time we did this, we got some people that we didn't really want to have on the air. So sorry about that. Okay, while we're waiting for questions, go ahead. We just got one. Let's see. I just want to read through it quick. I know it's not ideal, but field hospitals are very possible and will most likely happen. But maybe prepared to go to one, and then you have your team that you work with that may need to follow. Then you may arrive and not have the right conditions or tools to work with. Can you turn it down, or are you obligated? I guess if you're called into emergency service and you're not comfortable with what you're doing or where you're going, can you turn that down?
Yeah, I mean, they can't force you. I mean, they can take over your place, your operation, but they can't force you as an individual to do things that, are outside of your scope or you're not comfortable with, or where you feel you can't do.
And they are looking for people to go work in hospitals, or, either come back from retirement or go there if your center is closed. But again, that's something you've got to sort of volunteer for. I've
used this term before, the highest and best use. That's one thing that we have to remember here is when we've been talking about the possibility of our centers being turned into places where patients are taken care of as an intensive care unit, we're really not the ideal solution for that. The Army Corps of Engineers is looking for old hospitals that they're reactivating, military bases. I believe old hotels are being reactivated. I can't remember all the things that are on that list. It was a huge list. Schools, colleges. They're going to want to be able to concentrate people in a very in a large area where you can concentrate all of your nurses. They're going to want to manage 150 surgery centers. I think our best use, our highest and best use, is going to be taking on those surgical cases, maybe collection units and things like that. What steps are any surgeries under ophthalmology?
I think he meant what surgeries under ophthalmology would qualify as emergency surgery. And again, I don't know if it's emergency surgery or be just
again, it's elective versus non-elective. And I think in my view, having run an eye surgery center in the past, I can't imagine anybody questioning you about doing retina procedures, for example, because the danger there is quite imminent, or somebody that has endophthalmitis. I think cataract surgery, I don't know. I mean, personally, I feel that that's it's not elective, but it's something that can be postponed into the future.
If delaying something will really negatively affect your sight, it's not that if you do it in 2 months from now, there'll be a worse outcome, more risk.
Right. Somebody just mentioned glaucoma surgery, for example. I believe that would be important also to relieve the pressure on the eye, if I remember my eye surgery days. Yes, thank you. Other questions?
Let me see.
We are oculoplastic. We have decided malignancy, active infection, and vision threatening or potential blinding condition. I agree.
That sounds right.
Yeah.
Yes.
Anything related to cancer in general, something that you can do in order to stop the spread or the increase in the danger to the patient? I don't know that term. I can't pronounce it. Sue?
Anisometropia patients. I guess I can't pronounce it either.
Does any of my staff?
Anisometropia patients.
Might be helpful. And
it might not be.
Off balance after?
No.
Okay, I don't know.
I don't think it's.
Okay. Ann Geyer, if you can call in, you might help too, just as some of these questions come up, especially these procedures that I can't pronounce.
The one you can't pronounce is when two eyes have unequal reactive power. So I guess one is myopic, one is dioptic. So that's what that means.
Okay. And then she said off balance after first cataract. So maybe she's saying then that was a.
And you're on also.
I am on.
Thank you. Welcome,
Although
Ann.
I didn't know what that was.
State.
Thank you, Lori.
Thank you, Mary.
And she's saying, so I guess what would be our thought on that? They're needing a second procedure to kind of fix a problem that
Mary, can you call in?
If being off balance after a first cataract, does that mean that the lens isn't seated well? And is that going to cause problems for the vision?
Yeah.
I believe that means that they've done one eye, but they're trying to do the second one.
Mary DeMauro is on. She's our regional expert on eye surgery cases.
Hey, Mary.
Mary, can you hear us? Mary, unmute your microphone. Okay. Well, Mary's icon is here.
It says she's live.
John, I will say that I've had a number of my eye centers say that they're considering the second eye to be non-elective.
I think you're talking about second eye cataract procedure, right? Yeah, I think this is something different. Yeah. And again, I'm sorry, I don't understand.
Can you hear me now?
I can hear you now. Thank you, Mary.
Okay, sorry. Technical difficulties. Yes, we had this discussion with our physicians, and we actually this week had some of the docs had pulled in all their second eyes for the anisometropia issue, and we sent them off because in most instances they are not essential because the planned second eye could be treated with a contact lens. So they are not considering it that much. You'd have to be entirely off balance and like potential accidental damage to yourself. So it would be a rare instance that would be essential.
Thank you. I did get I'm actually looking at my YouTube feed here. Let me see if I can. I can't get the microphone at the same time. Does anybody else read it? So we are being guided that there are no more tests available to determine action or to determine COVID-19 testing. If your staff is exposed to somewhat probable or unconfirmed COVID-19 in this time, there are really no regulations regarding mandatory quarantine. What is your thought regarding this issue?
I have a comment on that. So, John, I think it came up today at the governor's press conference that there was questions regarding not having enough tests. What I'm telling folks is reach out to the local health departments, and then there is also a number for the Department of Health. I would contact them because there are more tests, and they will rectify that situation. If someone has been exposed, there is guidance on the Department of Health website that where you have to actually confine them until they have symptoms. They also put out a second letter, if anyone needs it, that's specific for healthcare workers. So, John, if anyone wants that, you can just send me an email and I'll get that out to you.
And I believe, Jenna, we've posted that. We posted that yesterday. Did we not?
Yep. Yeah, we did.
Okay. Thank you.
Okay, good.
Yeah, that's the return to work letter.
Correct.
And I did get a question from one of our listeners here. Please email that as well. Email me that as well. Please go to our website. You are one of our clients, and Alex, it's Jackie. If you can email that to her, but please, keep an eye on our website. I know it's starting to get pretty big because there's a lot of information posted up there, but that's a good way of doing it. Brian, do you believe that non-elective applies to offices as well? That is a great question because we've been focusing so much on ASCs. And Brian, if you want to call in, feel free. This is my friend Brian from New York City. So this is something that, Lisa, I haven't been paying a lot of attention to. And I don't know if you've been focusing the office side.
Mm-hmm. I have not, but I will say that office space, I think the same stands true. Even though you're not technically if you're not in Article 28, but I would say the same stands true, especially being prudent in this time.
Hey, John, it's Brian.
Welcome. Welcome, Brian.
How are you? I think that what's happening, I think the reason I asked the question is I have a lot of surgeons who are thinking of circumventing the order by potentially going to other OBS locations. And my comment to them is the order from the governor seems to be a little bit more wide-reaching to me than simply just going after facilities. I think he's making an order that's more broadly reaching and saying don't do non-elective procedures, don't do elective procedures at all. I just don't know if he has the authority. Does he think he has the authority?
He does.
Okay, good.
He does have the authority. Yeah, he does. And I do believe that he actually made a point of in everything that he has said over the last week or 2 weeks, he has never really emphatically said anything about enforcements and fines. He definitely did say that today a couple different times. So I would say, and he does have the reach.
Okay.
Helen Longworth is also on. Helen, if you want to call in, because I think you had some observations on the GI side, because I think this is kind of important too. Helen is with Physicians Endoscopy, or has one of the centers in New York. Thank you for the feedback there, at least because we do realize that a lot of our clients, or I'm sorry, a lot of our centers also are affiliated with physicians' practice. Mm-hmm. Okay, Anne went offline, but I did. Okay, any question? Brian, any other observations, especially from that standpoint?
No, I think from the GI side, we've been making our physicians understand that they really have to push off anything that's not even urgent to a later date. Most of them are complying. Some of them are difficult, but they seem to be getting it. From our ophthalmology center in Brooklyn, just like the previous person mentioned, we have been unable to make a case for cataract surgery for the most part to be anything but elective. We're probably going to try and maintain a reduced schedule for surgery, more like glaucoma-based surgery. We don't do retina, but there are cases of glaucoma that do need to be done. Other than that, we're probably going to be shut down for the most part.
And preparing for whatever might happen in the future with regard to the highest and best use of your facility moving forward.
Yeah, I mean, we in our endoscopy center, we don't have any ventilators clearly,
right.
I think the center itself is geared towards. It certainly could handle some capacity if they wanted to take over. You've seen the center. The one
right.
in Brooklyn, we do have 3 ventilators. I don't think they're good for long-term use. We did reach out to hospitals and offered it to them, and believe it or not, they weren't interested. And they finally did call us today, so they probably are interested. But that was after the governor's order, because I think they realized that the governor's making a reach, trying to grab all the ventilators. They might as well take them before he gets his hands on them. So,
okay. So we have a bunch of things that as we're waiting for questions, and please, any questions you have, send it to us in whatever way. We'll answer it as we go along. Here it is. Do we need to report under night ports if we are not closing but only doing urgent cases? The answer to that, to the best of my understanding, it is no. You do not have to report to night ports unless you're actually shutting down. So, Jenna, actually, you read something into the night ports reporting that might actually change that, right?
I thought that was Alex.
Oh, Alex.
Yeah. So if you're changing your operations in any way due to the emergency, you should be reporting to night ports. However, since this is a developing situation and we don't want everyone reporting multiple times for the same emergency, we recommend that it's best to wait till the end of the emergency for anybody that isn't actually shutting down to report. So that way you get the full extent of the emergency that you're actually reporting.
Right. And I don't think at this point, given that that night ports barely reports anything back to us anyway, in general, I don't think anybody's going to be spending a lot of time looking at that. I think the only comment I'd make there, though, if I were in health right now, I'd be probably looking at night ports to be able to determine who has shut down already. So that might, at least to that point, be a good source of information as places start going offline.
Right.
Any other questions? Okay, we'll continue to monitor that. I did want to, as you start making decisions about what you're going to do, in other words, what if you're going to furlough employees, lay them off, keep them on the payroll but tell them not to come in, here's some things that you need to be thinking about. Employees that must need to remain employed. Obviously, you're going to have somebody at the very high levels in the organization. You can't furlough your administrator and expect them to continue doing some type of work for your operation, because the minute you give a phone call to them, they're no longer on furlough. So you're going to have to maintain some very base level operations, including the ability to respond to whatever comes from the government or local hospital. And I know I'm getting some funky noises in the system here. So they might not need to be employed full time, but they're going to have to be available. So consider who you're also going to need to to continue to pay the bills, because those bills, some of them are still going to have to be paid. You're going to want to still collect money because that's going to be important. So maybe your billing staff and your follow up staff will have to stay online to do that.
John, if you might, can I jump in for a second?
Yeah, please do.
With the order that he just gave of 100% of personnel need to be off-site. I know that he's exempted healthcare. What about the administrative offices that are not technically healthcare? I mean, like, for example, I have inventory people. If they're not here, who's gonna receive those products? I mean, there are still things showing up. I don't think it's a realistic thing to expect 100% of the staff to not be on site.
Correct. And I think that's the point I was trying to get to here, is that you're going to need staff. You're going to need staff in order to be able to start to ramp back up again. I would consider something like supplying the organization in the anticipation that you're going to have to start operations again at some point to be critical. And again, documenting all of these things is extremely important part of this process here. Make sure that you document your decision-making process and put it in writing. And Brian, the governing body minutes, I'm sure your governing body is meeting, constantly right now. Documenting that in those minutes will be very helpful. I can't stress enough the importance of, having a good documentation trail, especially, and there's a potential in the future that we're going to be reimbursed for some of these things that we're doing here, as Lisa has pointed out. So making sure you're maintaining good information in that regard would be helpful. So yeah, to that point, I think people in the materials management, even purchasing right now, is extremely important.
And we did have some good ideas, but just yesterday, the days are running into each other. When we said what to do if somebody does have to spend time at your center, and there's no patients, what to do, how to keep them busy.
We have posted a lot of information about activities that you can be doing during this, use the term loosely, downtime.
And for new people, it's ASCPodcast.com. And
thank you.
Just look through that. And is that somebody mute?
I don't know. We have a frog-like sound coming on board. I'm not quite sure who it is.
I don't know if it's in our system, but if somebody's not talking, if they mute.
Or if there is a frog online, please,
please
log off.
Here's Judy with her little wooded background there. Sorry, I guess everybody can't see
It must be somebody. It must be either Lisa or Brian. Because
I'll drop off.
Okay, or yeah. Okay, thanks a lot, Brian.
Thank you.
Any other? So, are there any questions for Lisa while she's online here? And I thank you so much for your time, Lisa. This has been extremely generous. Oh, it was Brian. Brian must have had a frog there.
John has a pet frog.
Any questions for Lisa? Okay, feel free to stay online, Lisa. I did want to start talking about what are you going to do. In other words, before you start working from home, there's a whole list of things that you should be considering. Obviously take materials with you to be able to manage your board minutes, because you're going to be doing board meetings, offline. The board is going to have to be making these decisions about starting up again. You might want to run your committee and your staff meetings remotely. Again, anybody that's on furlough that you invite to one of these meetings, you're going to have to pay them for that. This can be on paper or electronic. Consider saving documents electronically on a password-protected and preferably encrypted laptop. So before you leave, take as much information as you can, put it onto a laptop. If you are a client of AHS, you already have an extranet, most likely, which we use through Dropbox, which is HIPAA compliant, to organize all of your materials remotely. You should also include, other great suggestions. Our team did some brainstorming this morning to think about all those things you need to take, and this is posted on the website. You should also include contact information for all of your employees, your board members and providers, and contracted providers, including anesthesia providers, for example, anesthesia providers. Take a copy of your policy and procedure manual, even if it's on paper, including the emergency plan, medical staff bylaws, infection control plan, because those are probably going to undergo a number of significant renovations over the next couple weeks, months. List of all of your vendors, and consider taking your contract binder or a copy of your contract binder with you for reference so that you can get a hold of those people right away. Take an inventory of your supplies that are on hand and what you will need before you start up again as possible. And if possible, get a list of all the expiration dates for all of your drugs so that you can reorder them if the expiration occurs prior to reopening. Make sure that you reset your min-max settings on your refrigerators as soon as you reopen. And as soon as you reopen, check to see if the temperatures were outside the appropriate range so that you determine whether the medication is still viable. Empty the staff and patient refrigerator prior to shutting down. Yes, just for the smell. Provide, if you are a client of Ambulatory Healthcare Strategies, please provide your alternate contact information while you are not on site so that we can provide updates and assist as you begin operations. For those of you that are clients of AHS, we will assist you. We'll maintain whatever we need to maintain while your operation is not fully functional. We'll do the communications with HHC. We'll help you with the communications with the Department of Health, et cetera, just like we always do. Again, for AHS clients, work with your with AHS to scan or copy any additional documents that you might need while you're working remotely. Alex and John, that's me, are the access rights administrators, so we can lock down specific folders so not everybody has access to it. Make sure all of your supplies are off the floor in the event of flooding. Who knows what's going to happen while you're not on site? So, you should be doing this anyway. They shouldn't be on the floor, but it's a good double check just to walk through your facility, make sure everything is safe. Unplug all unused equipment and obviously keep your file servers on so that you can access them, and make sure that they continue to be backed up. Reach out to your pharmacy consultant about how to handle refrigerated drugs. Reach out to your vendors of frozen allografts to inquire about how to maintain them during the extended period of shutdown. Consider forwarding company mail to a designated person during the shutdown. And as we've mentioned yesterday, we created a document that will provide some advice about what you can do from home, and that's posted on our website. That is all the content I have. I'm waiting for any other questions. Any comments from our staff? Anything that I've forgotten to talk about? Okay, go for it.
Press conference, did you go through all of that stuff?
So I did take some notes from the press conference. Let me just see. So let's just recap a couple things here. Okay.
Okay. Donna's on. I don't know.
Yeah, she's not Donna, please feel free to call in if you
Yep.
want to. So let's just recap something very important. If you are an ASC or clinic effective on Sunday, it is very likely that you will need to shut down. Hang on.
Okay, and Donna's calling.
Hi, Donna, you are on. You might want to unmute yourself, Donna. So as I was saying, as I'm waiting for Donna to connect, if you are a New York City or a New York State ambulatory surgery center or clinic effective on Sunday, it is very likely that you will need to shut down by Sunday. There are civil penalties for failure to follow the state's mandate. If you stay open, you will need to make sure that you can fully justify your decision and that the cases you are doing are critical to the patients. That means documenting in your board minutes the decision that you made, the types of cases you expect to do. On top of that, two things: keep a log of all the cases that you've canceled to justify that you are, to show that you are indeed looking at the cases and canceling those that you don't feel are elective or absolutely essential. And then for every case that you do, use the form that we've provided on the website to document the decision-making process on that. Donna, can you, we can't hear you if you're trying to talk. Check your, make sure you're not muted. Okay. Sorry, Donna.
Yeah, it seems to happen every so often.
Yeah. And again, points that were made during the governor's conference, some things that he was saying, basically. So this is another important point. One of the things that he indicated is for the patient population over 70 years of age are being told to stay at home, should not be going in for surgery unless absolutely necessary. So again, as I had a conversation with one of our clients throughout the day, is you might be deciding that those cases are things that you can continue to do, but your patient might have a different opinion based upon the state mandates that are being passed out right now. So if you're over 70 years of age, you still have a right, obviously, to determine what is, where you go or what you do. The doctor, can use that as part of the decision-making process. But ultimately, I think some of this stuff will inevitably be the patient that's just going to cancel on your behalf. What do we know about public goods? Mary, again. Mary, is your question about whether we have to continue paying for it or what? While we're waiting for Mary's answer, this is personal. If you, yes, a good question. So the question is: we know that the public goods pool are something that we have to pay on a monthly basis. If you don't file on time, the next filing date will be the 31st, which I can't do math right now, is in about 2 weeks or less than 2 weeks. I can't answer that. I have not seen any guidance on it, but given everything else that's going on and the fact that, one argument you can make is that, listen, I couldn't pay the tax because you told me to shut down and all of my staff had to go home. So I can't imagine them. Oh, and I guess the point I'll make is over the years, in my dealings with the public goods pool people, is they've been very good about waiving penalties and fines. So I guess I can pretty much comfortably say that if you're not able to pay on time, if you're not able to file on time, sending a letter, and if you need contact information, I'd be glad to give that to you. I don't think that's going to be a problem. I don't want to officially state that, but in the past, they have been very good about waiving fees and penalties during those times.
It's hard to see on a personal.
Yeah. One thing to remind people, if you do have a ventilator, the state is asking for it. Please contact the Department of Health. The telephone number is 518-281-5120, and feel free to lend your ventilator to the effort. They will reimburse you. I don't know how that they're going to do that, but they have said that they're willing to reimburse you for it. Again, the number at DOH, if you have a ventilator, is 518-281-5120. The governor is telling everybody to remain indoors to the greatest extent to protect the health of protect your health. Again, reiterating, hospitals have been ordered next week statewide to cease non-essential surgery. Now, he didn't, to the best of my knowledge, I think I listened to the whole thing. I don't think he actually specifically called out ambulatory surgery centers, but I can't imagine that he didn't mean to tell surgery centers also that there's to cease non-essential surgery. But to that end, it wasn't specifically stated during the conference. I have not seen, does any of my staff, have you read the actual official order yet?
Not yet.
Okay.
It hasn't been posted yet.
Okay. So we will post that, and I will I will also provide a link to it on my LinkedIn as soon as we get it. Jenna, remind me when that happens. Again, this is a good time to reiterate. Go to our website, ascpodcast.com. If you are on LinkedIn, feel free to connect with me on LinkedIn. The name is John Goehle, Goehle. I accept everybody that asks, and you can see my feed, and I post a lot during the day. A lot of it is about the podcast, obviously, but we'll try to push this information out there throughout the weekend and into next week. I would anticipate that we will have another live podcast on Monday. Hopefully we don't have to do it over the weekend, but if we do, we will. We are trying to get some lawyers on. We've had all kinds of scheduling problems with that. Believe it or not, they're very busy right now. But we'll try to get some guidance on this, well, in all aspects, especially employment law. Bruce Smith, if you have anything to say, I know that you're a good friend of mine out of Syracuse, a lawyer. I don't see you on right now, but if you have anything to add here, it's always great to have a lawyer on to talk things through. So if you have anything to say, feel free to call in, hit that call in button. Donna, I know you had a question, and it sounds like you couldn't connect with us. Can you post it to us or email? Or if there was a comment, whatever you want to share with the rest of us, feel free to do that. Or worst comes to worst, just call Jenna on the phone and she can pass that information on. We still have a lot of listeners online, so I'll keep talking. Hopefully we'll keep getting questions here. Any other questions at this point? Okay, continuing on with the governor's comments. Again, the governor said he's not kidding, that these are mandatory orders that he is placing, that hang on, that Jenna, can you read my email? An email just came in that might be relevant here, or Alex from McConville, Considine here in Rochester, and it seems to be somewhat relevant. Read it quickly, see if it might be effective for everybody here. Sorry, welcome to the live. By the way, none of us here are experts on broadcasting, so please bear with us as we're learning how to do all this stuff. So the governor stated that all mandatory, that it is mandatory that you follow the regulations, as Lisa talked about earlier. Be very careful about pushing the limits on the cases that you have. I've had a number of conversations today with centers that have really kind of seemed to feel that all of their cases, that they need to remain open. And I'm not about to make a decision that a doctor, should be making about this, but I think you have to be very careful and take, we need to make sure that essential services are available. And if you're continuing to do services that are not necessarily essential and taking resources offline or not allowing those essential services to continue, you have to be very careful.
And we've got a question. We are a facility that is providing essential services. What do we do about employees who decide they do not want to come in due to their own health concerns, but that we have not furloughed due to a reduction in staffing needs?
So this particular facility is providing a service that I think is justifiable in being essential, but they're experiencing a situation. They are one of our clients that their employees, I believe, are starting to say that they don't want to come in because they're concerned about the health consequences of it. And they have not furloughed those individuals. So if you have not furloughed those individuals, if you have not terminated their employment in some way, they are still employees of yours, I believe. And again, I'd love to have a lawyer call in
but does it
tell me about this, but I don't think you can't force people to come in, but if you have hired them for a specific purpose and they're not coming in, then and they're not sick or have not told you that they're sick, then you do have a right, I believe, to terminate their employment at that point. I don't think that's what you really want to do. I think that the whole thing is, what's going to happen with their
I'm wondering, like,
employment.
if they're compromised, is there some allowance if somebody is older, they're over 65, they have a compromised immune system? I think some allowances may be made for something like that.
I would certainly encourage you
at home
to loosely interpret your sick policy, your PTO policy, et cetera. Go ahead, Lori. I see you waving.
Yeah, I would agree with that, John. And perhaps you could put them in a situation that they would feel more comfortable. And I wouldn't make it known to all the employees, but if you have a valued employee that is able to come in but is afraid of, let's pretend, patient care, but they're excellent on the phone and can do your assessments, then maybe you want to assign them that task. Here's a good example of why you want cross-training, but if you can make it work for the both of you, then that's the best situation. But I agree, you cannot force them to come to work.
And there's a lot going on with regard to the employment situation, unemployment insurance or unemployment, short-term disability, et cetera, more than we can talk about in a podcast like this. And again, that's something I want to get a lawyer on to talk about. I thought I had one this morning that fell through, but we definitely will want to. Somebody waving at me. Unfortunately, I have. Okay. Hang on, let me just put this in another screen. There we go. So any advice that we can get, anybody that has information in this regard, we'll try to get on the not only on the air but also on our website here. A lot of that is going to continue to evolve as time goes on. Again, I know I'm repeating myself, but I want to give plenty of opportunity. Our listenership really hasn't dropped that much, so I'm assuming people are still listening.
I did hear from Donna.
Okay, go for it.
Okay, well, she wants to confirm that you believe that they can continue to do urgent cases as long as they can prove urgency. And there's actually another email from her a little bit before, because after they released the first executive order requiring people to go down to 75%, let me get this right, the New York State Empire State Development Corporation issued guidance regarding what essential services are, and they do have like the first one is essential healthcare operations, and they have a list, and unfortunately ASCs are not on it, but it doesn't say limited to, it just says essential healthcare operations including, and then they have laboratories, hospitals, walk-in facilities, vet clinics, elder care, home health workers, doctor and dentist offices, nursing homes, medical equipment providers.
Okay.
So I would assume if a doctor's office can stay open and continue to do procedures, ASC, again, it's essential procedures only.
Yeah. So again, to that point, again, I know people have been bouncing on and off. At this point, we do believe that you can remain open if you provide, if you have fully documented the reasons and the types of cases you're going to take on board. So there's 3 things you need to do. Number 1, hold a board meeting and make a decision as to what types of cases you'll continue doing and whether you're going to stay open or not. Document this in the minutes of your board meeting. If you need help with this, we've given some recommended policies on our website, ascpodcast.com. If you're a client of Ambulatory Healthcare Strategies, we are writing those minutes for you. If you want to become a client of Ambulatory Healthcare Strategies, call me and we'll help you through that whole process. That's number 1. Number 2, keep a log of all the cases that you're canceling because you've determined that they are not urgent, that they're not elective. That way you can justify the fact that you're not just globally taking any case that you can get. And then third, for every case that you are doing that you've considered essential, fill out a form. Again, we've provided that on the website. For every single situation in which you have done that case, to justify that, and document it in 2 ways. Document it in the patient's file, and then keep you a copy of that. I think we agreed, like, just create a binder and throw all of those in there. Eventually, you're going to want to have a log of that. Did I miss anything, staff?
No. This last question, though, had reminded me, the one that we just answered about furloughing employees that didn't want to come in because their own health needs. That's, again, I think we talked about it. We've talked about it a couple of times, but, start talking to your staff, or just what you know about them, whether there's people that would be willing to leave when you start cutting down your staff, if you get to pick and choose who might be more concerned, who has kids at home,
Right.
who has elderly people they're living with, so that the people that are staying are comfortable staying, and that the people that really are having a difficult time coming to work because of other needs caused by this are able to go home just to make good decisions.
You make another good point too, or something that just comes to mind is that as you're starting to make decisions about who to furlough, you might want to ask for volunteers. I never thought about this, but you're going to have staff that probably are working in the hospital already that might say, listen, I'm needed at the hospital. I as much as I love working in the surgery center and you are the greatest, right now,
you want that cross contamination.
right,
honestly.
exactly. Yeah, right now, I think my best use is in the hospital. So, feel free to reach out, as you start making some of these very tough decisions as to who to furlough. The people that are going to have a harder time finding a job during this time are going to be our non-healthcare professionals. I think nurses won't have any particular problem, but the non-healthcare professionals will have a tough time. So any of those that we can keep employed, by sending the other ones off. But I got to emphasize again, I do believe that this is probably in many cases a temporary situation. We might be shutting down, and what's happening in the background is the local hospital, the government is thinking about all of those additional resources that they're going to need out there, and they might be coming to us within a week or 2 weeks or a month, and then asking us to ramp up our services again, and they'll be very specific about what we need to do. So it's extremely important that we don't shut everything down. I don't think you should be laying people off, because ramping back up is going to be very difficult. Try to do that furlough. Remain optimistic that perhaps we have some other uses out there, and we're going to have to be very innovative here too, I think, as we go back online. Any other comments? Any more questions out there? I don't want to keep. This is a Friday, right? It feels like it's Monday of the following week right now. It's about 3 p.m. And I don't want to prolong this any longer, though my audience has not dropped off. So if there are any questions, is there anything? So we have a question from Denise out in Poughkeepsie. How you doing, Denise? Have a doctor asking for this mandate in writing. Jenna, I think you said it hasn't been posted yet. Is that correct?
Nope, I keep refreshing and it's not up. They
Okay.
did just update their coronavirus website with the things he talked about this morning, so I'm guessing they're probably going to be doing that soon.
Right.
But as of yet, on his executive order page, there isn't anything since yesterday.
Just a couple notes. Triple HC for Triple HC surveyors, and I think they're all online right now, has a COVID-19 webinar starting now. I'm going to have to bow out of that, but I'll listen to the recorded message afterwards. I believe that is all about how to, and we'll listen to it, because they're going to ask, they're going to be giving guidance to surveyors on what to be surveying when they are on site in an ambulatory surgery center right now. And Lori pointed out that some of the surveys are still continuing. Like, she has a Medicare deemed status follow-up survey coming up this week, I believe, and that has not been canceled. So keep in mind, there is still a survey activity going on. Can somebody confirm? I believe somebody just said that there's an ASCA call at 3 p.m. Anybody know what that's about? I wonder if they meant Triple HC. Any other questions? Thank you for all of your questions online. I'm trying to monitor everything. Anything on the emails?
No.
Staff, anything on that you can think of that we haven't talked about? It's focusing on infection prevention surveying. Thank you, Ann. Yes. Ann Geyer is actually listening to it online, and right now their focus is on infection prevention surveying. Again, I guess this is another good point to make, and Lori, feel free to step in here. We know that some of the rules are changing right now, but one thing that we can't compromise on, especially in the current environment, is the safety of our patients and infection control things. So you should not be compromised in any way. We talked about the importance of still maintaining face masks, not reusing face masks if at all possible. Laura, do you want to just talk a little bit about that again?
Well, I know that there is some guidance from the CDC that you can clean or reuse, like the respirator, the N95s. And one of the centers reached out earlier to ask about that, because there anesthesia providers are probably going to use it when it comes to intubation of patients, and there's a greater risk of being exposed to the respiratory portion, the droplets, et cetera. And my advice would be to, number one, if you're going to reuse your masks, make sure they're one provider specific. So if I'm going to reuse my mask, make sure I'm the only one that's going to use that mask, not somebody else.
Well said.
Number two, if I'm going to reuse the mask, then put a surgical mask over that. And then that will help prevent any contamination of the N95 mask during the process to which you would be at a greater risk of exposure. I think that would be prudent, and best practice, again, so that you're not having the mask directly from patient to patient to patient. You have a barrier between that mask and each patient, if you understand what I'm saying.
Yep.
When it comes to any other reusable stuff, if it is in direct patient care, I wouldn't reuse it. If there's a way to work around that, as we mentioned in prior lessons, that if it's your cleaning staff or whatnot, designate them to certain areas of working. If they're moving contaminated linen and that sort of stuff, if they wanted to put an overgown on, they can do that to protect themselves, but don't put any of the linen against you, because once you do, now you're contaminated. It's practice that we should be doing every day, that we don't normally wear a gown for, but now we really want to make sure that we're not contaminating ourselves any more than necessary. But infection control is going to be key in helping fight this virus. Obviously the social distancing, which I don't like the word social distancing, because we still need to be social so we can stay sane. But the polite distancing between people is essential, but so is continuing to maintain a clean and sanitary environment that's safe for people to come in and to leave from. So I think that any surveyor will be extremely keen on that, whether or not that's their forte or not. I'm sure that's what's going to be thrown down our throats, in the coming days, weeks, right now. So I would just say, stay diligent, keep your infection preventionists on speed dial.
Right.
That sort of thing. But, safe practices, you're going to be you're doing them at home. Doing them at work is key to keep the spread from person to person, unknown to unknown.
We did have another question. It has been a question we've answered, but we do have people bouncing in and out. So go ahead, Sue.
So Cindy says, sorry to ask again, I've already answered, but do you know if or when Governor Cuomo will shut down all ASCs, or if we just remain open and take procedures if the doctor feels it's necessary? And I believe we're saying, continue with essential.
Right. So again, there's three things we want you to do in this situation: is have an emergency meeting of your governing body in order to make a determination as what cases are emergency and which are not. I will tell you that many, if not most, of the centers that we work with on a regular basis are making a determination that at least temporarily they're going to cease operations because they cannot justify continued operations in the current environment, that those cases that they do consider to be non-essential are so small that they can't operate cannot remain financially viable during that time frame. I think another part of that is that they want to be prepared for that time when they might be called upon to do other, more urgent cases in the future. If you do that, so the governing body, you have a governing body meeting to make that determination. If you decide that your cases are urgent, and again, I have, quite a number of them that are deciding that, even orthopedic facilities that are deciding that those are urgent, and I understand that, then fully document that decision. So you have a right to do that, at least at the present time. There is no guidance, but we will continue to monitor this, and we'll get back to you if we do hear anything differently, or if they're much more specific about what cases are urgent or are elective and versus what is not. Third is that, so first is have a governing body meeting. Second is document it. Third is make sure that you keep a log of all the cases that you're canceling so that you can explain to somebody outside, justify to somebody outside that you are indeed canceling those cases, because we know that not everything you do in your center is going to be non-elective, or is going to be non-elective. And then fourth is for those elective procedures that you're performing, document in every single medical record using the form that we've provided on our website and we've talked about before, why you've decided to continue with that case. And I think at least at this point, you have good justification for remaining open. Now, that being said, keep the safety of your staff, keep the safety of your patients in mind. Don't take any unnecessary risks. Don't bring an 80-year-old into your center to do cataract surgery because your doctor has decided, you're going to have to step in as nurses here, to help them to understand that perhaps that's not a good idea, that patient's at risk and that the procedure is perhaps something that can be held off. So, that's an obvious case. I think it's an obvious case. I know that the world is full of a lot more gray ones than that, but you just have to make sure that we're not only doing the legal thing, but doing the right thing right now. And keep in mind, I think there's a lot of opportunities for us in the future. And I don't think that future is going to be too far away. And we want to be prepared for that. So if you continue to do procedures that everybody else in the country thinks is elective, and then down the road they call upon you to be able to do some things that are very urgent, that you're not going to be there for them. So keep your resources and be ready at a moment's notice to be able to take on what we're going to need to deal with in the near term. Any other comments? Our listenership, it was dropping and now it's back up again. So any other comments? Any other questions? Okay. I think with that, I do want to remind everybody, we have a lot. There's just I woke up this morning thinking that I'd have a 2-paragraph email to everybody today, because we had said everything that could possibly be said. And of course, how long did it last? That's where we are right now. There's just a lot of material. We'll continue giving that material to you on these periodic podcasts. Expect another live podcast on Monday. I don't think there will be a reason to do anything over the weekend. If we do, we'll try to push it out through the regular channels. I do want everybody to kind of hopefully have a good weekend. But be prepared for another podcast on Monday. We are also working very diligently right now and coming up with some opportunities to kind of get some education during this downtime here, so that we can get everybody up and running and fully ready to go on operation. A big part of what we're going to be doing over the next week as a company with our clients is starting the transition process from what do you do if you shut down to how do you get prepared for opening up again, and how do you make sure that you're not that you're able to start up again or transition to whatever the government or the local hospital is going to want us to do. So that's something we'll be working on. We'll be publishing information on the website to do that, working with our clients that we work with to help them through that process. Again, for those of you that are clients of Ambulatory Healthcare Strategies, we are here for you. We are working in the background. We are, we'll still be here while you are working from home. So don't forget to, obviously don't forget to use us. You're clearly doing that. Give us some guidance, but we do need to know your contact information, and we do need to know whether you're shut down or not. I think we are aware of that for the most part, but we have so many clients that it's been difficult to keep track of that. If you're not a client, listen, we give them a lot of information out there for free, and at this point, we're not worried about that. So if you still have questions, feel free to call me, 585-594-1167. I'll try to help you through it. Just recognize that when the phone started ringing at 11:45 today, every one of my phones was ringing. I had to throw some at Sue so that she could answer some of the call, and then she was on her phone. It became very hectic, and I please don't take it personally if I didn't take your phone call. I was just trying to handle an awful lot at the same time, and that's why I really think the podcast has been very beneficial. We're reaching out not only to our own facilities, but clearly when I look at the list of people that are online, the vast majority of them are not clients of ours. So hopefully we're helpful with that. Feel free to reach out to us at comments@ascpodcast.com with questions. If you want to have some material covered that we have not. We're trying to predict what all of you need, and we are getting a lot of great feedback from our audience about that. So send the comments at ascpodcast.com. Link with me through LinkedIn. What do you call it? I keep calling it a friend, but become a connection. Look for my name, John, John Goehle, Goehle, and you can find that. We also are on YouTube now. Same name, John Goehle there. You can see our live feed, so you can see all the behind the scenes stuff that's going on here, which is really exciting, as well as get all this content. With that, we do have to cover some legal things. So where is that? Oh, okay. Sorry about this. Well, that's it for this episode of the ASC Podcast with John Goehle. Join us again, and please consider becoming a patron by going to our website. And by the way, we've gotten a number of new patrons. Thank you very much. That helps pay the bills, and they are going up as we try to expand our reach here. So if you want to become a patron of the ASC Podcast with John Goehle, go to our website at ascpodcast.com and spread the word with your friends and people that you know about this podcast, and do us the honor of hitting the subscribe button. If you hit the subscribe button, you'll know when we go live at any time. You can do that in two ways. You can hit the subscribe button on the podcast, on any of the podcast apps, or you can go to YouTube, and whenever we go live on YouTube, we'll also be there. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, and Lori Rodrigues. Music is provided by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, and Encompass Healthcare Data Solutions.
And as of yesterday, our newest sponsor is BHG Funding.
For more information about our sponsors, please visit our website. If you're interested in advertising or sponsoring with the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.
Have a great weekend, everyone. Talk to you on Monday.